Recording in progress.
Good afternoon, everyone.
Good afternoon.
I think we can give it up to 12:05, then we can get started. All right. Good afternoon again. I hope I'm audible.
Yes, you are. You're very audible, actually.
Yeah. So I welcome you all to this afternoon's echo session, and today there's a team from the Poison Center in Zambia that will be talking about the importance of a poison center in Zambia. And with the team, the presenter is Dr. Sumbukeni Kowa, and there's two other experts who will chip in, and that's Dr. Abel Kapembwa and Ms. Mulape Kayange. So at this point, I'll hand over to Dr. Kowa.
Thank you very much, Donald, for the introduction and all. So as already mentioned by the facilitators, my name is Sumbukeni Kowa, and I'll be making this presentation on behalf of the team. So if you allow me, I'll just disable the video so that I can concentrate on this. Thank you. So thank you all who are here. All right, so basically this presentation is about creating awareness, and we would like everyone who's on the call to know what a poison center is at the end of it, why do we need this, and then the state of the Poison Information Center in Zambia, which is being set up. So as way of introduction, poisoning, as most of you will know, is quite a major cause of morbidity and mortality, with causes ranging from anything from accidental, homicide, or suicide. There's need for increased knowledge in making a diagnosis and of course, managing cases. Medical school can prepare to a certain extent, and wherever it is that health education is being taught, but it does not go completely far enough. And the center is basically there to assist with the both diagnosis and management. The major goal at the end of the day is for prevention of these cases from occurring. And that's why the center is very, very important at the end of the day. All right, so what is a poison center? It's a specialized unit that gives advice and plays a key role in preventing, diagnosing, and managing cases of poison. This is straight out of the WHO handbook. Of course, the primary role is clinical, which includes giving clinical advice, and to some extent also in treatment. However, you have to remember that some of the cause might come from a home. All right, it might just be a worried mother or a worried parent. So the primary role is similar. And in such a case, of course, the advice will be clinical, what they can do at home, or if they need to bring the suspected poison patient into a health facility. So at a minimum, it's an information service, but it can include an emergency room and a toxicology lab as well. The information and advice is accessed in real time, and this is through a telecommunication platform. As you know, poisoning is basically a medical emergency in most cases, so that's why the information is ideally in real time and through telecommunication. So why a poison center? Zambia, being a member of the World Health Organization, is also part of the adoption of what is called the IHR 2005. IHR stands for International Health Regulations. So the purpose of the international health regulations is basically to prevent, protect, control, and provide a public health response to the international spread of disease. So that's the purpose of the IHR. So under this, these international health regulations, countries are required to have the capacity to detect, to be alert to, and also respond to public health events which are caused by chemicals. So chemicals here is a generic term, and for our purposes here, we're talking about poisoning. Poisoning can be anything from biological, chemical, drugs, and a whole lot of other range. So one core capacity necessary for the country to meet this particular obligation is the availability of Poison Information Center and also access to toxicology lab services. Okay. So as part of the problem in Zambia, cases have seemingly been on the increase. Okay, so. All right, so there's both an increase in awareness of the public and also an increased index of suspicion in our clinicians and pathologists. Data is still quite little, and the reason is we don't really have full knowledge of where most cases are coming from, where they're occurring, the common types of poisoning, and how are these cases being managed. So Facilities may have this information, but it's we don't have a central place where we can put all this data together. Okay, and that's where the center now becomes important, as we can aggregate all this and it can be available for those who are looking for statistics. We do have a few statistics generated by, I would say, the lone toxicology lab in the country. So this data, however, may only be a tip of the iceberg. Why do I say so? Because a good number of cases do not make it to the toxicology lab. So from around the country, I don't know how many people actually send the sample. Most of what we get are autopsies. So those will eventually find their way, but actual clinical cases in the hospitals and those from the community will not mostly reach the toxicology lab, and those will not be captured. So that's why this data is basically a tip of the iceberg. So this is some of the information from our toxicology lab. So these are statistics from last year, 2023. So you see what's being shown here for patients who were admitted to hospital. Right, so here we have not said which hospital they were admitted to, but when the samples came to the lab, they came from a hospital. So mostly the University Teaching Hospital, which is in Lusaka, Levy Hospital within Lusaka, we might get one or two from outside, but it's not very common. So you notice that regardless of whether it was homicide, accidental, suicide, the most common cases were as a result of it looks mostly like drugs in this particular case. Okay, so the next one is showing autopsy samples. So autopsy, for autopsy, you see that mostly it looks like alcohol, and then chemicals like mostly pesticides, as you see there. Right, so as already mentioned, so most of the cases, drug intoxication and alcohol for autopsies. So the center, what it will do is it will basically cast the net wider to capture as many cases as possible nationally. So in addition, the Poison Center can prevent unnecessary treatment. I'll just give you 3 examples of cases we received at the toxicology lab. Oh. Okay, am I still audible?
Yes, you are audible.
Okay, great. So 3 examples. The first one, we got a blood sample for a child who had ingested detergent at home. The request from the clinician was that we do a drug level. You can see from such a case, if this person had called the Poison Center, would have simply told them that detergent is not going to be deadly, and all they needed was to rehydrate the child and no need to take any blood samples, but a blood sample had actually been taken. So number one, if this is a private hospital, you've charged the patient for a lab test, you've charged the patient for an admission, it could prevent that kind of loss of monies in such a case. Second example, blood was received for a patient who had overdosed on their ARVs. So most patients are currently on dolutegravir. So, and the blood sample was for us to do a blood level again. So here, straight advice is that there's no need to take a blood sample for a blood level. This patient just requires symptomatic treatment and supportive as well. Dolutegravir being relatively a new drug, not very new, but relatively new, we also don't know much about the effects of an overdose. So in such a case, the first thing that you do is just emergency supportive and symptomatic care. Third example was a patient who had a suspected snake bite, and the request was for antivenom. So this patient on clinical assessment had a mild swelling at what was thought to be the bite site with no other symptoms. So the center would have given advice, this patient just needs observation. And I think by the time they came to the hospital, already quite some time had passed. So as long as 12 hours have passed and there are no symptoms, there's no need to rush into antivenom. So just a few examples, there could be more out there on why this center is very important to prevent over-treatment of some cases like this. All right, so what type of model are we looking at? So the center we're looking at is one which will have information service, but in addition, also clinical services and the toxicology lab. Why? Because where the location is, there is a lab, and we're surrounded by clinical services. We're basically located within a hospital. So, but otherwise you can have a poison information center which just gives information with no clinical services attached. All right, so the other reason why it's important, it's this thing called toxicovigilance. So toxicovigilance basically helps to identify cases when they occur and also to generate data. And this data will help us then to prevent future cases or predict where cases will be coming from. In Zambia currently, poisoning is not reportable. I stand to be corrected, but because of this, a lot of cases then go unnoticed and unrecorded. So we would like actually to lobby that poisoning becomes a reportable case. And as a result, we'll be able to capture as many as possible. Right, and of course, that's the role of the PIC, just to try and implement this toxicovigilance as a routine practice. So it's an encouragement to our clinicians. In addition, there are other people who handle chemicals, like the agrochemical producers, those who deal with agrochemicals, commercial farmers, etc. All right, another important role is prevention. For this prevention to be effective, there's certain information that we must know. So we should know where and how people get access to various agents. So if it's chemicals, where are they getting them from? If it's herbal material, natural toxins, where are they coming from? Okay, so things like the scale of illicit supply and use of narcotics, psychotropics, that kind of knowledge. And of course, the PIC can't generate all this information. We need to work with people who, other arms of government and the private sector who are closer to this type of information. Also important to understand our local fauna and flora, to be aware of toxic species. So fauna and flora is basically our natural plants, our natural animals, and things, our environment basically. And be aware of things in the environment which are toxic. And also importantly, working with traditional healers, also to understand their therapeutics. So whereas traditional healers are a good thing, it's not strange to have cases where someone visited a traditional healer and not too long after that, they had to be admitted into a hospital. Or unfortunately, they died. So these are some of the things we'll need to understand so that we can work together. Another importance is, of course, coordination of antidote and antivenom supply. So this applies mostly to uncommon or rare forms of poisoning, like snake envenomations, where availability of antivenom is not very widespread. So that's one thing that can be coordinated by the Poison Information Center. Of course, for other antidotes, most will be available in the clinical area and through our pharmacies and emergency units. So what's the current state of the Poison Information Center in Zambia? So it's located within the premises of the National Food Laboratory. This institution is located within the University Teaching Hospital complex in Lusaka. We have 4 specialists in poison information. These were trained with the complements of Syngenta Zambia. Syngenta is an agrochemical, I suppose, producer and distributor of such chemicals in Zambia. So it was part of their corporate social responsibility. We do have access to poison databases. These databases basically provide up-to-date information on cases of, most poisons. So this information is available at our fingertips. And if you're looking for such information, it's easy to access through any of our specialists here. Okay, so a call line has been launched. This call line was to give a trial run for the University Teaching Hospital and Levi Mwanawasa hospitals for the emergency units to access. So there hasn't been that much by way of cause. So we're wondering if it's because these are referral centers and most poisoning will probably occur at a lower level. So that's why we're making this presentation for awareness, so that we open up this line for now anyone and everyone to access the center. So currently it's just a telephone number, but we should be rolling out a toll-free number which can be accessed by everybody. All right. So this is the number currently. Please take note. So it may cost you a few units, but remember those few units could save a life and save you money as well from over-treating a patient. All right, so please take note. I've deliberately stayed there for a little while so that you take note of this number. So this number currently, it's not 24 hours, but can be accessed during the hours of the day. As you can see there, it says between 8 to 5 p.m., Monday to Friday. I know I'd said poisoning is an emergency, and it has no time when it can occur. So this is just part of the trial run. If you really must call on a weekend, I suppose we can open it up, because this line will be available with somebody at any one point. All right. All right, so what is our way forward? So we're in our infancy, still a work in progress. I think the moment we get our toll-free line, it will work better for people calling in, because then it doesn't cost you anything. Okay, and then at that point, we may eventually open it up to the general public. So at the moment, we're trying to keep it to hospitals, emergency rooms, clinicians, wherever you are around the country. Okay, so of course, at the end of the day, we're looking to reduce the cost of unnecessary hospital admissions. We will only know this once we see how the center is operating. Also, we should be able to provide data on the true incidence of poison cases in the country, and this will also be known on at least a quarterly or annual basis. We should be able to give that kind of data. So for now, it's mostly awareness creation, and we do have our own 5-year roadmap of where we want to see this institution. All right, and I think that ends my presentation. Of course, we got some references from quite a bit of material, and thank you very much to everyone for listening. At this point, I'll hand it back to our facilitator, should there be any queries which we can address for you. Thanks again.
Thank you very much, Dr. Kowa, for that beautiful presentation. So at this point, we'll open it up for questions, clarifications, and also for those who are unable to speak, you can use also the chat. I'll be able to read out the chat, the questions in the chat. So there's a hand from Komena. You can go ahead as we wait for other hands.
Thank you so much. Thank you so much, Dr. Donald, for the presentation, and Dr. Kowa. It's been a very informative presentation and very interesting. Happy to see that we're making progress when it comes to poisons, especially in Zambia. I can see that a lot of the data that we're looking at, or at least a lot of the things that we're looking at, there's a lot of unknown information. I know the presenter touched on just the way forward in terms of the Poison Information Center. I was hoping to get a bit more information, especially the steps, at least I know that he talked about the establishment being at the national, the food place in UTH. Is there a way to, I don't know if there are plans to have this center maybe separately, or indeed it will just be, will continue to be stationed in UTH. And I also wanted to find out about the antivenom, especially for the snake bites, for some of us who are usually in the farms, especially on weekends, even though the emergency line is usually only used during the week. But how readily available is our antivenom? And maybe also just if you could give a comment on storage of the antivenom. Then secondly, is this antivenom a universal antivenom for all types of snakes, or there are just some snakes that if you are bitten, you might as well say bye? Thank you.
All right, thank you very much for those questions. I believe we've taken note. Any other hand before we get to answer? All right, I'll just read, there's one more comment probably before we get to the answer. So from Yvonne Piri, it says, do the people in charge of the hotline review patients in person, or they exclusively give advice on how to manage the poisons? Then I'll add one more. Good afternoon, this is from Evelyn Banda. The issue of anti-snake venom, how readily available is it? All right, I think we can start with those. I'll hand over to you, Dr. Kowa, and the team of experts on the call.
All right, thanks very much. So the center, you don't need to have centers all over the country. You can have one center and it covers the whole country. I'll give you an example. In South Africa, they basically have one center and it covers the whole country. So the reason is it's a telecommunication, or you're communicating through telephone. So they can be reached from anywhere. You don't have to be close to where the center is. All right, so that's a poison information center, information only. I did allude to the fact that you can have one where it includes clinical and a toxicology lab. So where, yes, I think such a center, I think, is what you were probably asking about. If we can have such where you have this information center with both where patients can be seen and treated as well. So it's not really necessary to have all that cost implications. Most hospitals will have a clinical unit and they'll have doctors there who are well capable of handling these cases. So the center is just there to give that support where they might lack a little bit of knowledge or something. Okay, so it's basically supportive. Otherwise, if you are already in a clinical center, you should be able to manage most cases. With regard to snake venom, I've seen, yeah, this is quite a concern. Anti-snake venom is not readily available. So this one has to be sourced. So because of having an information center, one of the things that WHO as part of support would do is actually then make antivenom available. So for antivenom, there are two types. There's what is called polyvalent, meaning it can cover a number of species of snake, all right? And then there's monovalent, which is then specific for one type of snake. So it's taken into account most of the common venomous snakes into account. And provided you reach a center which has the antivenom within good time, you should be able to do well. So here it's a time factor. So yeah, so there are very few snakes which do not have antivenom. But for our purposes, I think in Zambia, the polyvalent should be able to cover most of our snake species. One of the questions in the chat was whether we can see patients as well. So it's mostly advice, yes. So for us here in Lusaka, because we are in a clinical center, we can actually also do hands-on, right? But otherwise, the primary role is the information and advice. If the clinician wants any of us to go in and assist, and we're nearby, we should be able to do so. All right, so I have 3 of my colleagues as well on the call. So should they feel that I must have missed something, they are free to chip in.
All right, so any contribution from Dr. Kapembwa or Ms. Kayange before we move on to the next set of questions?
Yes, good afternoon. Thank you so much, Dr. Mumba, Dr. Kowa, and everyone else. Dr. Kapembwa. I think Dr. Kowa touched almost everything. Maybe just to consolidate on maybe like our role. So, yeah, the Poison Information Center itself, yeah, essentially it offers that advisory role, because people have got information poisoning on their fingertips, and also poison information databases which they can easily consult. But however, it's important to mention that we all have a medical background, and also the part of the training involves much of the management. And for a person like me, Dr. Mumba, who are literally seeing patients also in our various fields, we tend to actually see these poisoned cases. Yeah, not just advising, but also manage. And therefore, I'm seeing a lot of snake bites at Kayange, as well as poisoning from pesticides, a lot of those. And now it's important as clinicians or doctors to understand that the range of poisons is so much wide that we shouldn't just be talking about, for instance, organophosphate poisonings and rushing to give maybe atropine and whatnot. You find that there are other resurfacing or surfacing chemicals. Yeah, the rodenticides, for that matter, you find that they come from a group of maybe anticoagulants. Yeah, and if we miss that, they are dangerous anticoagulants. We've seen a rise of zinc sulfides, heavy metal sulfides. And if we miss those, we find that we may lose a number of patients. Yeah. So just to again say that we do attend to clinical cases, but of course it's within our facilities. But essentially, if the need for this service increases, you may find that maybe we may start reaching out also to the other centers. Thank you so much. That's what I wanted to add on, Dr. Mumba. Back to you.
All right, thank you very much. I don't know if Ms. Kayange is on the call, but please feel free to just chip in. So I'll go on to the next set of questions. So I'll start from the chat before I come to the hand. So there's Ziambo, who's saying, looking forward to when the call center will be 24/7, seeing a number of poisoning happening in the evening and in the night. Benzu says, thank you so much for the presentation. At what point should we call the hotline? Okay, so there's a question there. Then Kayani says, good afternoon. Is this hotline very accessible, more especially deep in rural areas? I'll batch this together because there There are similar questions. The Miriam says, good afternoon. For continued data collection from facilities that are very far from the center, are there courier services provided for the particular interest? Okay, and then the last one is from Karen, who says, good afternoon. What is the turnaround time for toxicology lab results for 2 places outside Osaka, or what are they uploaded? Are they uploaded on a particular site? So Komani, you can go ahead. I don't know if that's the old hand or Komena, sorry.
Yeah, this one is a new hand. Thank you so much.
Go ahead, then the panelists can answer.
Okay. Can you get me? So sorry, I had dropped off.
Yes, you are loud and clear.
All right, thank you. I may have missed it. Did you share any treatment guidelines for these poisons? Because I think when we are in hospitals, all we know is give atropine or give some fluids. What does it really mean to stabilize the patient when you've got a poisoning case? So are there any treatment guidelines available? And if they are, have they been distributed in most of the centers? Thank you.
All right, thank you very much. Over to the panelists, you can go ahead.
Okay, thank you for the questions. I'll pick some. Yeah, I'll leave those to do with the lab courier services, then around time to Dr. Kowa. Start with the last question. I think it's about the initial assessment and the management of a poisoned patient. So essentially, the first thing is what we all know. It's resuscitation. Yeah, so resuscitation, the airway, breathing, circulation. And in most cases where patients are severely poisoned, you'll find most guidelines are talking about early securing of the airway. And these are the things which depend on the actual health system, per se, which has to be strengthened. Yeah. But the protocols and guidelines are there for individual cases, because we have a wide range of those poisoning cases. And some you may have antidotes, others, use of antidotes can even be more harmful to a patient. Yeah, so essentially it's a big question. It can take us the whole day and whatnot. But in a nutshell, in most cases, you do your primary assessment, primary survey, the initial management, resuscitation, and then also in most cases, you talk about symptomatic and supportive treatment. Symptomatic and supportive treatment, like that. Then the what line accessibility, yeah, this line is very much accessible everywhere because it's about network. The moment we've got the Airtel number, but eventually we are going to have a toll-free line. So it's accessible, and you can call us from everywhere. The issue with courier service and turnaround, I think Dr. Kowa can take up that time. And at what point should you call the PIC? Well, as an attending clinician, is at every point you feel you need instant help. Yeah, that's at the facility level. However, you look at the concept of poison information centers as a response to public health. In that, I mean, we want people to call even before they start off going to the hospital. Yeah, so if we reach a level where we can intervene at the community level, at the household level, even better for us, because it has been proven that most cases which reach the hospital, they were not supposed to actually reach the hospital. Hence, you waste money for transport, you waste resources at the hospital level because in the hospital, we're always on high alert, high level gears, so we always want to treat. But if these patients don't reach your hospital, we advise them safely, then we'll reduce the number of people presenting to your facility. But if these patients reach the facility in the cases of moderate to severe envenomation or poisoning, then you can call us whenever you think you need the extra interpretation of the symptomatology, or if you want help in terms of the treatment, you can call us. Dr. Kowa.
Thank you very much. So regarding data collection, with data, remember as long as you're able to call in, that data can be given through voice and we'll enter it in a database. So we do have a database where we can enter, and then this database eventually is going to be made available for anyone who would like access. The other way, of course, we have the general way that data is shared through, I think it's DHIS. So eventually we would like to feed into there and have any data on poison so that we have it in one area. So it doesn't matter where you are in the country, as long as you're able to call in, that data can be given as such. So it doesn't have to be sent physically, no. Turnaround for toxicology. Like I said earlier, the cases of poisoning are medical emergency. So obviously, one almost immediately in real time. So in many cases, where you need this kind of service, I mean, there are certain drugs where you want a drug level. For things like paracetamol, for example, paracetamol is very common all around the country. And hence, paracetamol poisoning may be a common thing as well. All right, so there the drug level is very important. And then, of course, we know that paracetamol poisoning also has an antidote. I suppose that's another topic for another day. We don't know if this antidote is actually available throughout the country, but at a basic minimum, it should be one of the drugs which is in our essential drug list. Because paracetamol is so common and commonly used, the antidote should also be available on a similar scale. So anyway, so for most cases, we actually don't, there's no need for you to do a blood level. The clinical symptoms and all will kind of give you what the case is. And most of them, as Dr. Kapembwa said, will have either specific management or general symptomatic and supportive treatment should be able to take care of it. Because, yeah, lab results turn around and the lab is only in Lusaka. There's no way to work. You're in, even if you're in a close, I mean, even if you're in Lusaka, in Chilenge, for example, and you have a case and you send a blood sample to our toxicology lab, it's very rare that you're going to get results in real time for you to help to make a decision to treat that patient on the same day. So, yeah, it's a very good question, but yeah, it's a tricky one. Most times you'll be able to clinically assess and be able to manage just on that premise. And that's how most cases are actually managed. So we'll be there to, as a guide, we'll be there to give all the necessary useful information, even management information as well. Thank you.
All right. Thank you very much, Dr. Kowa. We're almost getting to the top of the hour. Probably I'll take one last question if there's any burning question.
I see two more in the chat.
Okay.
Probably.
Actually,
so there's one which says, kindly give a brief guide on the use of black charcoal because there's an abuse at community level for any case of poisoning, and what are some specific cases where it can be used? So, and then the next one says, what deliberate policies have you put in place for effective community engagement? All right, so those two are from the same person, Dawood, and then there's another one here which says, if protocols are available, can they be shared? All right, so black charcoal, I would presume this is activated charcoal, but then if you say community, you are basically talking about charcoal itself, and you grind it into a powder, right? So it's very useful, I guess. It's a chelating agent, so it will try and mop up most of your whatever has been ingested. Unfortunately, it's not great for certain types of poisons, especially your liquids, your chemicals, things like acids, alkalis may not respond to this. But if you've taken a drug overdose, yeah, it's something that can be taken, and it just helps to limit the absorption of the poison. So I'm sure the community has learned this from somewhere, and that's why they actually use it. I'll allow my colleagues to add if I've missed anything there. Then on deliberate policies to engage the community, this one, of course, the center may not have the capacity, but of course that's why we need all the partners. We need the districts, we need the province from HQ. So obviously our reach is extended through all these arms. So of course, yeah, we definitely need to be in touch with our provinces, districts, who are much closer to the community than we are. Protocols, yes, the same protocols we use in the center can actually be made available to clinicians for you to just update yourself and be conversant with poison cases. So currently the accessibility is quite restricted. You need to be paid up to access these databases, but we'll see if our sponsors can allow maybe some of our major centers to have access to these. All right, so while I've been speaking, two more have come in. There's what's the estimated period or time when the activated charcoal should be used upon consumption? And then the next one is, in most cases, it must be given. Oh, okay, fine, that's an answer. So Dr. Kapembwa, if maybe you can shed some light on that.
All right, thanks so much, Dr. Kowa. Yeah, Dr. Mumba actually responded. Yeah, in most cases, we want to give it as early as possible, 1 to 2 hours post-ingestion. But also, it's important to understand what kind of substance or chemicals consumed, because some chemicals could be what we call slow release, or they may reduce the motility of the GIT. Hence, you may consider to give even in prolonged times. Okay. Yeah, but as a rule of thumb, the 1 to 2 hours stands. Then it's not in every case. I think Dr. Kowa touched on that one. It's not in every case. Like he mentioned the acids, corrosive substances, activated charcoal won't work. In cases of heavy metals, the activated charcoal won't work. So we are talking about the activated charcoal being taken as a drug, okay, being understood as a drug, where we should understand that is the indication and the contraindications, for instance, for use of activated charcoal. Somebody who takes something which will block the motility of the GIT, you are not going to give activated charcoal, because why? You are going just to balloon up the GIT, which you may risk even perforations and so on. Yeah, that's the use of activated charcoal. So I think in futuristically speaking, for the protocols, that's where the issue of toxicovigilance comes in, where we need to map, you know, the different poisoning cases occurring in the country. And if we understand, for instance, in Kulungu, northern part there, we see there is a cobra, Mozambique spitting cobra there or something. We should at least advocate to say the treatment protocol for a cobra, okay, Mozambican cobra or Cape cobra or a central nervous envenoming insect, snake bites. We need these steps. And we will need to ensure that in those places, mountainous places, for instance, we have readily available antivenom. That should be done. So essentially, we have protocols which have been developed from outside the country. And those people, when they were developing, that is South Africa. At the moment, we are using the tox base for South Africa and the UK. When they were developing, they were using local information, local data. Yeah, so even in our case, we need to sit down, collect the data, and then formulate protocols responding to the epidemiology of the poisoning cases. And that's what I can say.
Thank you very much, Dr. Kapembwa. We are now almost at the top of the hour. We need to wrap up, and thank you very much for everybody who logged in. Just probably wrap up, as we've learned that the Poison Information Center, or the Poison Center, is quite important. And in a case where you've correctly identified a substance that has been ingested, they will guide you correctly on how to manage. As we've seen in most of the hospitals, especially clinical space, we tend just to know a few drugs that we give. For example, I think Dr. Kapembwa highlighted on the use of, on the management of organophosphates. So everybody, when they see a pinpointed patient, someone who presents with pinpointed pupils, they think everything is organophosphate, and they'll start giving the atropine. But this Poison Information Center will be able to guide you exactly, depending on the other symptoms that the patient has, will present you with. And for your own information, these patients, in terms of presentation, they crisscross. They're what are called toxidromes. So the symptomatology of how they present, they crisscross, and it's very, very cardinal that you consult, even if you think you know, because and that's why, even if the guidelines could be given, it's quite bulky, like Dr. Kapembwa highlighted. It's quite bulky, and you definitely need some help and some guidance on how to go about the management of these different patients. Last but not the least, in a case where you fail to identify the chemical or the product that has been taken, even a screenshot or a photo that can be taken can be sent to the Poison Information Center for identification. And the good part is that even things like snakes, if a snake has been killed, it can be photographed, sent to us, and we'll further, if we can't identify it, we'll further send to a pathologist that we've made contacts with, especially in South Africa, and around the globe who are able to identify the snake and give guidance. I think with that, unless there's anything from the team, we are done. Dr. Kowa, anything you wanted, maybe any last thoughts before we close?
Thank you, Dr. Mumba. You've basically covered the whole range. So for me, my message is this line is open. If you do have cases or data which you want to share, we're open to receive that. So at the moment, it's 8 to 5 p.m. However, like I did say, I mean, it's a mobile number, so it will be on somebody at any time of the day. So if you really must call after 5, I suppose, yeah, there's probably no harm. But we'll be more available between those hours for now. But yeah, it will eventually open up and be free for all 24 hours a day. So thank you very much again. There was one more question in the chat, which I did respond to. I hope the person has been able to see that response. So thanks, Dr. Mumba.